So I guess we'll get started. I'm Susan Chapievsky. I'm a geropsychiatrist at the Veterans Hospital, and I am responsible for the second-year resident experience in geropsychiatry. We also have a geropsychiatry fellowship. And today I am here to present our current year fellow, Kristen Lee, who is going to be talking about her experience this year in nursing homes. And unless you do child psychiatry or child psychology, you guys are all going to be geriatricians. So because we're not training enough geriatricians, and of course the population's aging, so we're really hitting a big demographic bump in the road. I was thinking about the caucuses last night. Demographic bump in the road, and there's just going to be a lot of old people and not enough people to take care, who are specifically trained to take care of them. So Dr. Lee is a native of South Korea and did her medical school in Korea, ended up doing her residency in psychiatry at the Mayo Clinic, and is now our fellow in geropsychiatry at the VA. It's a one-year fellowship. And will be, when she leaves us in June, she'll be going and working, doing outpatient geropsychiatry work at United Hospital through the Alina system. So that will be a referral. We don't have a lot of geropsychiatrists in the community, so it's very exciting that Dr. Lee will be doing that. So, and I think there'll be hopefully time for questions at the end. Dr. Lee.
Thank you, Dr. Chapievsky, and thank you so much for coming to the Grand Round. It's my great pleasure to be here. Today, I'd like to talk about nursing homes and psychiatry. I have disclosed, and by the end of today's talk, audience will be able to recognize common mental health needs in a nursing home, identify benefits of a non-pharmacological approach, and provide practical guidelines to address some of the common issues in a nursing home. And to begin with, I'd like to have you think about a couple of things. So there was a study that used the assessment tool to assess the needs of elderly individuals living in a nursing home in Poland. The results showed that the most commonly reported unmet needs by residents were two of these: company, psychological distress, drugs or medications, money, or memory. I'll just let you guess. And the second item is, according to Centers for Medicare and Medicaid Services, or CMS, which of the following is an adequate indication to use antipsychotics in dementia patients? Insomnia, restlessness, wandering, fidgeting, or behavioral symptoms that present a danger to the resident or others, and they are due to mania or psychosis. This might be too difficult or not, but again, I encourage you to think about this. So let's talk about nursing homes. I don't know if you've been to a nursing home, and chances are many of you have, because there are so many people who reside in nursing home. Like as of 2015, there were over 15,000 nursing homes in the United States. So, you likely have someone could be grandparents, parents, or relatives in the nursing home. And the number of residents, there are 1.4 million and increasing. And the two graphs below are from CDC. So this one marked with yellow line represent the nursing home population. The magenta color in the bottom is the percentage of residents who are under 65. So as you can see, majority of them are old or older. And here, the dark blue represent people with dementia diagnosis, and the light blue is for depression. So as you can see, there, close to half of residents have dementia and or depression. But I haven't really been to a nursing home. I mean, as a resident, I've seen people coming from nursing home to ED or inpatient or to clinic, and I've seen people discharging to nursing home, but I didn't really have a chance to be there and see what it's like in person. And for me, the first opportunity came when my daughter performed her ballet in the local nursing home. What I saw there was, the pleasant old, the ladies in wheelchair. They were really excited to see little ones dance, and there were staff members nearby tending their needs. And when I started my fellowship at the VA, I had this great opportunity to go to a nursing home in Minneapolis every week. And still, I couldn't really picture it in my head before I was there. This nursing home has a website, and on website, which is very well organized, they have photo gallery. So the two pictures over here are from their website. So this is from Christmas. They had a visit from Santa, and residents received presents. And this looks like they had a party in their patio, and they had this gigantic rabbit. It looks fun. And when I went there, so I would be there on every Wednesday. I get there when they're about to have breakfast, and I leave when they're about to have lunch. What I saw was not that, special events or excitements, but their regular days, typical days. And again, that allowed me to see the needs that are there, that otherwise that I wouldn't be able to see. So this nursing home has 4 different floors. The first floor is for the most functioning people. And I was very surprised to see so many people with severe mental illness. But if you think about it, people with severe mental illness ended up going to 2 major places in the United States. One's a nursing home, and the other one is prison. So I saw many people with diagnosis of schizophrenia or other psychotic illness or substance abuse and things like that. On the second floor, they have ventilator unit. And this nursing home that I've been going to is one of the 2 nursing homes who can provide ventilation care. And the 3rd and 4th floor is for people who, needs skilled nursing help. And again, being there every week gave me an opportunity to see the different needs. There's this assessment tool called Camberwell Assessment of Need in the Elderly, or CANE. This was developed in UK in year 2000, and it has been widely used in Europe to assess needs that are met or unmet in the elderly. And they assess 24 different items, and they ask the questions to residents and key staff member and caregivers. And again, you can find a lot of publication using this tool on PubMed. And there was one from a nursing home. And in this particular nursing home, if you look at this column here, for odd man needs. So how they assess is, they first ask if there's any need that are, identified by staff or resident. And if there is a need, then they ask if the needs were met or unmet. For needs that were unmet, the two top area was psychological distress, like does this person feel sad, angry, anxious, or fearful? Or company, does this person need any assistance in having social contact? And for these two issues, people don't necessarily come to the clinic readily unless it becomes really severe. So when I was there, so I've been there for about 8 months by now, and I've been asked to see residents for these issues, like interpersonal conflicts, depression, anxiety, suicidal ideation, substance abuse, decision-making capacity, evaluation, psychosis, and dementia. So they sound quite similar, don't they? But there are differences as well, and I'd like to highlight them. As a Geriatric Fellow, I get a lot of consults in the clinic. It could be from other mental health providers or primary care physicians or other providers in the community. The nursing homes, when they ask me to see patients in the nursing home, they were better in not asking me to prescribe pills. That surprised me. And also they were very motivated to identify and do something when residents were not happy. So what would you do when you're asked to do something in a nursing home? Well, there are a lot of medications that we use as a mental health provider. And so many residents are on psychotropic medications, really a lot. Like if you look at patients who come to the nursing home, 73% of them has some kind of mental health diagnosis, and 85% of entire residents are on psychotropic medication 3 months after admission. So that means even people without any mental health illness are on psychotropic medication. And close to 20% are on 4 or more psychotropic medication. That's a lot. And this table is from CDC. So they show number from 2011 and then 2013. So most commonly used medication is antidepressant, like over half of them are on antidepressant. And antipsychotics has been particularly concerning. And this has a long history. So already back in 1980s, people were worried that so many patients in nursing home were on unnecessary antipsychotics. And at that time, they were typical antipsychotics. And they were also worried about abuse in the nursing home. So they started working on decreasing the use of antipsychotic. And 1990s came, and atypical antipsychotics became available on the market, like risperidone, quetiapine, olanzapine, and they were also monitoring and regulating the use of physical restraints. So the use increased dramatically. So CMS, the Medicaid and Medicare, they were paying more money to cover antipsychotics compared to like antibiotics or blood pressure medication. And the studies have shown that antipsychotic use in dementia patients increase the risk of mortality. So, as you know, FDA released the black box warning in 2005 about the use of antipsychotic in dementia patients. And the federal government took a really aggressive action to decrease the antipsychotic use in nursing home. So this graph is also from CMS. Like starting in 2011, the use of antipsychotic has been going down, and it is keep going down. And how did they do that? By really aggressive regulation. So one of them is this 5-star quality rating system. So CMS, they send out this, the staff to nursing homes without scheduling, and they assess health inspections, staffing, and quality measures. And the result is available to public. So you Google or use whatever search engine and look for, the nursing homes in Minneapolis, for instance, then you can get these results. There are 5 stars, and some got 1 out of 5, 3 out of 5. So consumers will know this. In nursing homes, they're very motivated to have good ratings. And also, if you don't comply with the regulations, then you can be fined and not be reimbursed. And these are the quality measures that federal nursing home regulation addresses. And the highlighted ones, let me read it for you. Who have depressive symptoms, and they generate the number for this particular nursing home and compare it to state average and U.S. average. Who received an antipsychotic medication, who were physically restrained. So nursing homes, they have been doing a lot of work to address depressive symptoms and use less antipsychotics. And when it comes to using pills, so now, we're aware of the risk and the limitation of using, the medications. Well, we can justify risk if there are good benefits, right? And behavioral symptoms of dementia can be very challenging. But again, unfortunately, we don't have a really good medication that can address behavioral symptoms as of yet. And often we see sedating the behavior as a positive outcome. Like, for example, this is not the patient from the nursing home that I've been going to, but I have seen this patient with dementia in a nursing home, and his troubling behavior was that he flushes the toilet at night. I mean, as his dementia progresses, the simple action of flushing the toilet and the water swirling, that became so entertaining, so when he does that, he giggles. And it's a problem because he does it at night. And for that, he was on gabapentin, because it helped. Maybe he was sleepy, right, and less likely to be up at night and flush the toilet. Is that really what we should be doing with the medication? CMS, they are very specific in identifying inadequate indications for the use of antipsychotics. They are wandering, poor self-care, restlessness, impaired memory, mild anxiety, insomnia, inattention or indifference to surroundings, sadness or crying alone that is not related to depression or other psychiatric disorders, fidgeting, nervousness, or uncooperativeness. And nursing homes, they are regularly educated about the proper use of antipsychotics. And, we see a lot of old patients with long list of medications. And it is important to know that we have to be very careful in using medications. Beer's criteria is something that is practical and helpful in using medication in the elderly. So this is a list that has information about potentially inappropriate medication use in older adults. This was first proposed by a geriatrician, Dr. Beers, in 1991, and has been periodically updated since, most recently in 2015. And it is also available like on the App Store, so you can conveniently download it and quickly take a look. So, if we have to think outside of pills, what can we do? First of all, I like to emphasize that there's always a reason. A person in distress has a reason to feel that way, and it is important to find the reason, because that's often where the solution is. So medical assessment, I don't think I'll have to go in detail. I bet everyone in this room would agree that we have to do a thorough medical assessment. And we look at medications and we rule out infections or other, the medical conditions that could be causing troubling behaviors or mood symptoms. But just a couple of things on medications. Because again, so many of our patients will be on such long list of medications. You can do a lot by reviewing medications and removing or reducing medications. For example, before you consider starting cholinesterase inhibitor for a patient with dementia, please also make sure that you are removing or reducing medications with anticholinergic properties. There are so many medications that we use to take care of bladder symptoms that are very, very anticholinergic. Let me tell you about this patient at the nursing home. So this very pleasant lady came to our nursing home after a surgery for colon cancer. She also had diagnosis of Parkinson's disease and unspecified psychotic disorder. And it didn't take long to notice that she had really troubling dyskinesia, and she was paranoid, and she was having hallucinations, and they were quite unpleasant. She was on levodopa, and she was also wheelchair-bound, not walking, and not falling. So when levodopa was discontinued, her paranoia, hallucinations, and dyskinesia resolved. Yes, she was shaking more in her hands, but, she didn't need, such thing as antipsychotics. And there are general approach that we can take when we think outside of medications. If possible, please see the person in person, because you can gather so much from direct interaction, and also when it comes to communication, you can really deliver your treatment beyond words. And brainstorm with a caregiver. For instance, for the gentleman who loved to flush toilet, instead of gabapentin, you could have been more creative. You can, brainstorm with the nursing staff to see if there's any safer way to keep him happy and distracted and not be disruptive to others. And it's also important to see the environment through patient's eyes. And let me tell you about the patient that I saw at the nursing home. I was asked to see the patient for irritability and anxiety. And this patient has history of benzodiazepine and opioid dependence. And she was still on a lot of opioid, like a lot of morphines and oxycodone for disabling arthritis. And she was working hard with this very compassionate physical therapist who worked with the goal of her walking again. But her arthritis was so bad that she did not make enough, the progress with each session. And, they couldn't justify her receiving, the physical therapy after a certain period, which is, fortunately, a case in many nursing homes. So, and then she became very difficult with staff. She was irritable, she was not complying, and she was refusing other treatment that were offered to her, so I was asked to see her. And I also was given her medication list, and they were highlighting, she's already on Klonopin, we are not comfortable in increasing her opioid more, but maybe we can offer Klonopin. This is an example where we quickly grab medications to make us feel better. We want to be helpful for patients, and we use medication so much and it's easy enough so that we're tempted. Her complaints were not about having more benzodiazepines, but she really mourned the loss of the physical therapist who really cared about her. And there were other things that she wished for in interacting with other residents and staff. For example, she had really minimal use of her hands because of severe arthritis. So if someone moves stuff around in her room, which is her home, then she has no way of fixing it. People close the door when they leave, and she cannot open it again. So that bothered her greatly, and she was demoralized. So what we did was we put signs on her door, please do not close, and we made sure that we put things back in a place that she wanted before we leave her room. I mean, if we were invited to someone's room, then, we'll be polite enough to do that automatically. But in an institution like nursing homes, we unfortunately often forget. And another thing that I like to share, in case when you have an opportunity to work with someone when there's not urgent issues going on, in like non-crisis situation, why not be proactive, not reactive? So when you're asked to see a patient who are in nursing home and who's doing better, don't just check their medications and schedule follow-up appointment, but please consider doing the cognitive assessment. There are many cognitive assessment available. Like my favorite one is MOCA, but there's Folstein, Kochman, or what's the other one that occupational therapy often use? SLUM. When you see elderly patients, a lot of them have cognitive impairment. It could be from medical illness or dementia or mood disorder. And you can be easily fooled if you try to judge one's cognitive level without actually using a cognitive assessment tool. So when they're well and they're in your office for regular checkup, please consider doing a cognitive assessment. And for people who are elderly and are doing well, there are needs that are easily come up in an appointment. So it is, the better to be proactive and ask about these aspects: accommodation, food, self-care, daytime activities, memory, mobility falls, and things like that. So back to the first two questions that we saw in the beginning of the talk. In a study that assessed the needs of elderly individuals living in nursing homes in Poland, the most commonly reported unmet needs by residents were accompanying and psychological distress, something we mental health providers can help. According to Centers for Medicare and Medicaid Services, which of the following is an adequate indication to use antipsychotics in dementia patients? So my presentation will be a success if when you see an elderly patient next time, and when you're about to use a medication and you think about the proper use of medication. When I prepared this presentation, these two books were greatly helpful, and they're really entertaining to read as well. Dementia Beyond Drugs. This, it's more for mental health providers. It gives us very practical tools when we interact with patients with dementia. And Being Mortal, probably I don't have to talk too much about this book, but it also gave me insight about our health system, including nursing home. And these are references. And I'd like to thank Dr. Chepievsky for giving me this great opportunity, and Dr. Myers, who've been helping me at the nursing home, and nursing staff and residents who continue to teach me good lessons. Thank you so much. I guess I'm well ahead of time. If you have questions, please feel free. Yes?
I know it's supposed to be about no meds, but where does valproate fit
In
for agitation?
Right. People do use it to manage agitation. So the consensus so far is that valproate is not any superior than antipsychotics in addressing agitation. As a matter of fact, there is a guideline published from Canada. I'm blanking the name of the guideline, but it was published in 2012. They reviewed the medications that are used to treat agitation or other behavioral symptoms in dementia patients, and they said divalproex does not have a good evidence. The reason is it comes with a lot of side effects. Significant drug-drug interaction, falls, sedation, liver toxicity. So it didn't really justify the use of divalproex.
It seems to be incredibly popular for the geriatric folk.
Correct. And that is true. Because, again, we don't have a good medication to offer to begin with. When it comes to efficacy alone, antipsychotic is still the best one. Again, if we don't think about the risk, then antipsychotics there, but there's federal regulation, and there's a lot of warnings with mortality, so we try to avoid that. And there have been many attempts to use other medications. Valproate is one. They've also looked at antidepressants like citalopram, sertraline. Some studies will show modest benefit, but again, to this date, we don't have a really great medication to offer. So for very challenging cases, like patients who would not respond to non-pharmacological intervention and pose a safety risk to self and others, then we ended up sedating the patients or do our best. Yes.
This is a rhetorical question, but I'll ask it anyway, and that is, if 50% of the population that live in nursing homes are depressed, what percentage of that is because they're living in nursing homes?
Very good point. Very good point. So being in a nursing home yes, it is something. It is something. And nursing home has been existing for years. It's not like nursing home, like current model of nursing home suddenly popped out. It's been there because that's how we see our elderly or people with medical needs. So they're segregated, they're institutionalized, and when they interact with people, often it's called therapy, like occupational therapy, physical therapy, and they're isolated from their family, and yeah. So, very true. Being in a nursing home may be very depressing, and what can we do about it? Yes. I'm sorry, I couldn't hear it very well.
I just wanted to know if you referred to the book Being Mortal, right, by Atul Gawande, and it talks a lot about this institutionalization, how we treat our elderly, geriatric care. I want to know if the medical field, geriatricians, are starting that kind of conversation, or the institutions are looking at those recommendations at all.
Oh, great question, and Dr. Chapyaski would like to answer.
It's a great political question, and it basically has, yes, geriatricians would love to do this. We would love to have that discussion. The problem is we're training fewer and fewer geriatricians. And Dr. Gwande's book talks about how, talked about a really great geriatrics program we had here at the U, and that got shut down. And the problem is reimbursement. So that we have this medical model for treating behavior in people who are in insane situations like the nursing home. And there's this medical model that says, and that we're physicians, so we give people drugs because those are the tools that we physicians use. And so we're asked to give drugs in a situation where people, it really, as Dr. Lee mentioned, it really is about changing the environment. And there is more depression in patients in nursing homes. People who have the bed by the window have less depression than people who have the bed next to the door. So there's a lot of situations. We don't have that discussion because everything is driven by money. And I would love to be able to prescribe PETs and music therapy and aromatherapy and massage to patients, but that's not reimbursable. So, this is a societal issue that is really sad. So, yes, the few of us who are here have that discussion, but it's not, it's really more about drugs because you can prescribe a drug in 5 minutes and it takes an hour to spend with a patient to try to figure out what's going on, and also the caregiver, because the caregiver, the behavior problems in a patient are more likely to be related to the roommate or issues with the caregiver than they are with the patient. But we don't have psychiatric consultation in nursing homes because it doesn't pay. And Dr. Lee's been, has had an invaluable experience, and it's really been a benefit to the geriatric team that she's consulted to. But it's a huge problem.
Thank you, Dr. Chapyaski. Oh, yes.
Do we know if there's a difference in care between nursing homes, ones that are faith-based versus non-faith-based? By faith-based, I mean coming out of religious tradition. Not that I'm salty, I'm just wondering if there's a difference.
Well, great question. Unfortunately, I do not have the answer to that.
So there are these ecumen homes. I believe that there's some in Duluth. They are run by a Catholic organization, and they really have pioneered the use of non-medical means to help people be more comfortable in their environment. So there are models out there. It does happen to be a Catholic organization, and there have been articles in the New Yorker about them and other places. So the Ecumen group, I don't know that they have any places down in the cities. Would you know? No. Any?
Ecumen, you mentioned Ecumen?
Yes.
I think they just bought some land from Luther Seminary.
Oh.
They're going to be putting up some type of senior facility.
Well, that's exciting because there's hope for me, for me when I need care, then. So.
Yes, I don't have any data that proves that nonprofit nursing homes get worse or better rating on 5-star rating. But when I looked at 5-star rating for nursing homes in Minneapolis, that was the impression that I got. Again, I didn't do any statistical test for that. The nursing home that I've been going to, only 2% of their residents are on private pay. So majority of them are Medicaid and Medicare, and budget is always tight, which translate into the number of staff. So I think that that all will change the rating of the nursing home. Yes.
My question has to do with suffering and when to intervene and how to intervene. Although I'm a child psychiatrist, I was called upon to see a patient who had a bleed and a craniotomy and was left aphasic, mildly paralyzed, and then transferred to Light Tower over in St. Louis Park, which is a new facility which seems really excellent in terms of care. I could go there every Friday, and we have a big conference, and then I see Patricia, and she is she was put on Depakote at subtherapeutic levels, but as she's gotten better, she seems to be becoming aware of her infirmity and her difficulty discussing and describing it, except in words and facial gestures. The question we've come to is, when do we relieve suffering because of her agitation and her difficulty and frustration over communicating? Depakote has been now raised to just barely therapeutic levels, and she's not on any other meds. And the real goal is to do it with therapeutic intervention rather than medication intervention. But the question is when to say, well, there's suffering here and we should relieve that. And would you discuss that, both of you, if you discuss that matter?
So the question is about treating suffering with medications. Yep.
Yes.
And that is really not an easy question. It is a challenge that we see very frequently in practice. So again, when we see patients suffering, it is very important to find the reason. And the first approach could be with environment rather than using medication, like Depakote. What could calm patient down, may help with disinhibition, but can cause cognitive impairment, gait instability, and whatnot. So it becomes finding a right balance and finding out what's most important to patients. Would you like to add anything?
Yes, what is Dr. Czapieski's view?
Well, our goal is always to relieve suffering. I mean, that's sort of what I think of. I don't think of, I agree with Dr. Lee. Medications aren't what we look at relieving suffering. So you're asking about, this is a young girl?
She's 74.
Oh, sorry. An older woman. So, the question is, what is the suffering about, and how, what's the best way to relieve that? Is it to give her, is it to give her some touch? Like, again, I'm a huge fan of pets, and I often prescribe them for my patients. So, is there a, I'm a cat person, so that would relieve my suffering if I had a cat. What is it that gives her quality of life? I think that if for 74-year-olds, the big issues are what has my life meant up till now, how I'm struggling with dependence versus independence, and those are really the things to discuss with her. If she has a strong religious faith, you would make sure that there was someone involved who could talk to her about that, and also talk to her about what makes your life worth living going forward. What are your goals? And really look at ways of helping her just sort of deal with mortality. I mean, there's just an infinite number of interventions we can do, none of which involve medication. But they involve time and touch, which is, again, we don't get reimbursed for that. Does that help?
Yeah, that's helpful, and it's what is in fact being done. This family is has a great deal of resources, and so they have 20 round-the-clock private nurses, and they pick the private nurses regarding the relationship that they can have with Patricia, and who makes it with her and who doesn't, and I've got all kinds of schema to divert, to listen, and try to read between the lines. This is where child psychiatry training comes in handy, because you can look at body language and facial expression and kind of get the gist of what the patient's trying to tell you. It's really quite marvelous.
There's actually a lot of similarities between child psychiatry and adult geriatrics, because we have patients who really aren't able to express their needs, so we have to figure out what it is. The problem is if a 2-year-old misbehaves, we don't give them haloperidol. We do give old people haloperidol if they misbehave. So, and I think that there's similar issues with that. And I also, dealing with families is really important. The one thing we do deal with, again, that probably you don't so much in child is the issue of mortality. And doctors do a really good job of keeping people alive. And family members do a good job of, want to have their their family member alive. We forget suffering. And if you ask the patient, they're more interested in quality of life or relief of suffering than they are of longevity. And another, I guess, issue with old people we don't have with kids is that there's trade-offs for everything. So you give them a medication, you're trading efficacy versus risk of side effects. You're saying, patients saying, I want to live as long as I can, but that may mean that the trade-offs are lack of mobility, and pain and lack of function. So doctors don't do a good job of discussing that with patients. I try to, what are your end-of-life goals? Again, based on the Gawande book that Dr. Lee mentioned, and most doctors don't have that discussion with patients. I feel it's imperative that we do, and I often feel like the angel of death because no one's ever talked to them about it, and here I am talking about it. And it's a difficult thing. I'm really blessed at the VA to have time to talk to patients.
Another book that's good here is Oliver Sacks' book, The Mind's Eye.
Yes.
Which helps people understand what's going on. The point about meds is that she has periodic episodes of anguish and suffering. And it seems like the time you get a med into her and it takes effect, it's kind of over with already. So it's sort of the horse is out of the barn already. And so, there's like, what good medicines are there? And I'm not even sure the under-the-tongue clonazepam or Zydus works quick enough. And if it's too powerful to leave them zombie-like afterwards.
Well, if people just have spells of crying or sadness or agitation or whatever, they're not frequent, why give them medicine? I probably start with an SSRI like citalopram before I would try an anti-epileptic or antipsychotic. Again, looking at potential for harm versus benefit. But, people who have dementia do have these spells of behavior, just like, you think about a 2-year-old melting down. It's very similar. It's a brain that gets overwhelmed and the person's the brain's overwhelmed with stimuli and the behavior then deteriorates because the person doesn't know how to adapt to what's going on.
Thank you.
Any other questions? Yes.
To step into that conversation and start talking about the grief and loss issues that are going to happen. I mean, they're part of life. And I think allowing people to have that type of conversation about the families too. I think especially with people with Alzheimer's where they're really not communicating, but families are going through a lot of grief and loss. And I think that's where a lot of the healing and the ability to find some serenity in it can happen. But I'm just wondering how often you see staff or facilities providing that kind of opportunity.
Oh, absolutely. I agree with you. It is important to have conversation about grief and losses. And many people postpone it, including providers, because we all feel anxious about death and, feel powerless over loss. Through my training, I was able to see that to have the conversation is not actually as hard as we fear. In the nursing home where death happens commonly, the staff are quite good with talking to family and people. Outside of that, like before people go to a nursing home, I think it's important for us to be mindful in starting the conversation.
Agreed. I also wanted to put in a plug for aging. It actually, if you look at old aging, healthy aging, people are actually, we're a lot happier than young people, and actually aging is associated with positive hedonic tone. And basically it's because when you're young, you're like, oh, am I good enough? Am I smart enough? Do people like me? Can I make it? Is this going to work? That stuff goes away when you get older. And so people are happier. And I just wanted to make sure there's this idea about aging as being, really sad. And yeah, I'd be depressed too if I lost my spouse and I had this illness and et cetera. Not true. And so when we're dealing with a nursing home population, we definitely have that's a different population, or certainly a population where people have had a mental illness all their life. In terms of the patient with Alzheimer's disease, the person with Alzheimer's disease, 9.5 times out of 10 is clueless that they have this problem. I mean, it's a blessing in a way that they really lack insight. So that usually when I'm diagnosing Alzheimer's disease, the patient's like, yeah, whatever, and the family is crying. So you're really working with the family, and there is just a lot of work. And when I see patients with Alzheimer's disease, you spend 2 minutes with the patient because they're fine. basically because the caregiver is spending all this energy and to keep them fine. So there really is a lot of family work. This is, I got to tell you, geriatrics is a great field. It is so, it is, there's so much good we can do. So anyway.
Thank you.
I think it's probably time that we.
Yep. Thank you so much for a great discussion.
Thank you.
That was very nice. Are you going to do that every day too? It will be different because the audience will be different. Yeah. Okay. Yeah. I mean, I have two more. Yeah. Thank you.
Yeah.
You have been